Are you presenting, Dr. Lang?
Yeah, let me see if I can figure out how to get my slides up here, Emily.
Okay, and if you can't, let me know and I can do it for you.
Let's see here. Can you see my screen?
No.
Huh, okay. Let's see what I can do here.
Oh, now I can see your I can see your screen, but it's not your slides.
Okay, let's see
So
if
you
I can
probably just need
move
to.
something around here. How about that?
Yes. Are you able to put it into the presenter mode?
I think I can. Let's see if yeah, I can move around. Is that moving?
It is. I don't know if you can put it in presenter mode though, so we don't see the sidebar and then it makes it bigger. But if not,
Uh,
no worries. I think we
let's
can
see,
all
if I
see the
try to press
slides.
the wrong button, I might be totally flummoxed. So why don't we try to go with this? So
Okay,
yeah,
great.
great. Thanks for, we're happy to, say a few words on what we're doing over at the Needle Exchange in Tacoma. And a few words about the Tacoma Needle Exchange that I've learned since I've been working with them for the last 2 years is that this is an organization that's one of the longest standing needle exchanges in the United States, greater than 35 years. And very interestingly, they run NASIN, which is the North American Syringe Exchange Network, which is essentially a buyer's club for almost all the needle exchanges in the United States. So what it is, we set up the Tacoma, getting together with Paul and Stephanie, the bosses, Paul, the executive director, and Stephanie, the head of operations. They do a great job. They've got a great staff. They're really fun to work with. We set up the Tacoma Needle Exchange Free Clinic, which is a WHAA free clinic. The medical personnel are volunteers involved with mainly the VRP program in the state. Many come from the Medical Reserve Corps of Pierce County. Myself and Joan Halley are our two docs. I'm a retired ER/IM doc, and Joan's a retired family practitioner. We have some other nurses that work with us as well. And we're supported by Washington Department of Health for point of care HCV and HIV testing and dried blood spot testing. Thank you, Emily, and the rest of your team for supporting us. This is obviously important for us. So anyway, I would describe what we're doing as part street medicine, part drug user health. We do no billing for any kind of services. Overwhelmingly, the largest issue we deal with is wound and skin care. Our second biggest problem, in my view, is hepatitis C and other sexually transmitted and bloodborne infections. What are we doing differently for hepatitis C? Many people we're seeing without any appointments whatsoever. And in many people, we are able to treat them without doing venipuncture. And we're relying heavily on dried blood spot testing to give us more testing flexibility. In addition, for the other flexibility, in addition to that. Couple of points I wanted to talk about. Opt-out testing. I think most people on the call understand that concept. Just the idea of being more aggressive about testing. We're not there yet at TNE. This is something I really want to work on, though. Another thing that I want to talk about is facilitated telemedicine, which is essentially having a third person involved in telemedicine between the doctor and the client patient. Also dried blood spot testing, really one of the cornerstones of what we're doing. And really what I'm trying to do is approximate the systems developed at Central City Concern in Portland, Oregon, the work of Andy Seaman and Arsalan Shah and their group down there. I've really looked to them and seeing how they're dealing with their population, which is basically the same type of population we're trying to serve at the Needle Exchange. Paul and Stephanie are very dedicated to providing services for their clients, not only the Tacoma Needle Exchange, but also the other underserved and homeless communities in the area. So let's talk about a couple of patients that we've treated here. I think that'll be a good way for me to emphasize some of the things we're doing. So the first guy I want to talk about, let's call him Bill, 38-year-old Caucasian male, current drug user. While visiting TNE for supplies, he found out that medical care was offered. I was there that day. He wanted to take a look at his leg wound, which he's had there forever. When I asked him about hepatitis C testing, he said, "Oh, I know I have it. I don't need to be tested." When I offered the possibility of the potential of being treated, he said, "Oh, you can do that?" So anyway, Bill has no veins. he stated that he went to his methadone clinic, and when he got there, they wanted to draw some blood and they wanted to do some tests and talk to him about hepatitis C, but they couldn't draw blood, and both sides just kind of gave up on it. So we kind of talked a little bit about what we might want to do, and I wanted to clinically evaluate him, accepting that we weren't going to be able to draw blood, and evaluate him to make sure that I didn't feel that he had decompensated cirrhosis, in which case I would be willing to consider treating without further venipuncture. So we did a HIV point of care on the spot there today. We took a dried blood spot card for the HCV, RNA, and hepatitis B surface antigen. We sent those off with the idea that we laid out a plan on what we were going to do, how we were going to treat him. He was very delighted with that thought. So about a week later, we got the test back, and I contacted Bill, and we got going on his treatment. So the second person I wanted to talk about is, let's call her Mary, 58-year-old Native American female. And we came in contact with her with the AbbVie Elimination Van tour stop in Tacoma that we sponsored a couple of months ago. I think most people are familiar with that. They brought in the Cepheid point of care machine. So we screened a ton of homeless people at that time. And that's the way we came in contact with Mary. So Mary lived in a homeless shelter. That was one of 3 sites that we did testing that day. She had no phone call or she had no phone. She had no email contact. So I talked to the very helpful social worker at the Stability site, her homeless shelter, Maddie. And I asked Maddie how we might contact Mary. And she said, well, we have a phone here that the clients can use. And we sort of arranged a time where Mary might try to call me. Well, that really didn't work. So I got back to Maddie and said, Maddie, what about if you bring Mary in your office and we have a 3-way call? And she said, well, that ought to work. So anyway, we got Mary in the office, and the 3 of us were chatting. And so this was my first example here that I wanted to bring up for what I would call facilitated telemedicine. So talking to Mary, we identified she did have a PCP. I said, great. Let's talk to your PCP. Let's work on working together to get you treated. Mary seemed very interested in getting treated. So I called up her PCP, and she was familiar with Mary, but Mary had never come to the office once. She'd seen her a couple of times in the hospital for problems, but she had never followed up for the office in the office as she's supposed to. Her primary doctor is at one of the tribal clinics in the area. So we kind of scratched our heads and figured out, I knew from talking to Maddie, the social worker, that she was going to be there for 3 months. So we said, well, let's just treat her here. I think that'd be our best bet. So on the spot there, when I was talking to her PCP, she looked at the records. We can look at her records. We saw some recent labs. She had an excellent APRI FIB4 scores, and she had a recent negative HIV. So we said, yeah, we can just go ahead and go for treatment. So I had the meds sent over to the homeless shelter, and Maddie has been very helpful in initiating her treatment. So let's look at the gold standard of HCV treatment. Some of you people are probably saying, gee, Tom, some of the stuff you're doing here is heresy. So let's just talk about this a little bit. Anyway, the experts, of course, are the AASLD IDSA guidelines, and these are the liver and the infectious disease people. This is their website here, a lot of great information there. I really like their most recent simplified guidelines. These were put together primarily to promote use of the Cepheid test and treat on the same day, but I find them really useful for kind of like a bare minimum of what we ought to do before we treat people. So when you look at their recommendations compared to what we're doing, they're recommending an HIV, hepatitis B surface antigen, ALT, AST, which are liver tests, and a platelet count, and a pregnancy test if needed. So the ALT, the AST, platelet count, of course, are used for calculation of the APRI and the FIB4 scores, which are non-invasive measures of liver damage. A platelet count cannot be currently done without venipuncture. However, when you look at the website there, their statement is essentially the panel continues to recommend treatment for all patients with chronic HCV infection. They have a few exceptions. Essentially, they want you to treat everyone unless they're ready to die. So, when we look at patients like Bill probably is not going to die anytime soon. So I can look at him and say, Bill does not have the evidence of decompensated cirrhosis. I think we can treat him with the information that we have at hand, with supplemented by dried blood spot testing and our clinical evaluation of talking to him and examining him. So let's talk about dried blood spot testing a little bit. For our clinicians out there, think heel stick in neonatal pediatric blood testing. This is used very prominently here, but it's really not used very much elsewhere and really not used very much in this milieu as well. So blood can be obtained by a finger stick. We drip it onto a filter paper. I've got a card here, but I don't really know how to show it. When we get off this slide, I'll show you the card we use. But think it's just like a stool guaiac card. It's a little card, and we're done filling it out, dropping. We have 5 little circles that we drop the blood in by finger stick. We can just drop it in the regular mail. So we get the results back in 7 to 10 days. Not ideal, but good enough for my view. So this simplicity, in addition to being well accepted by patients, not having to have all the other things around blood drawing, we can use this in the field pretty easy. However, as we mentioned, currently we cannot do a platelet count with this by dried blood spot testing, so we couldn't meet what would be considered accepted standards. So let's talk about a few points along the care cascade. As I mentioned, opt-out testing, I think is really important. Instead of just hanging a sign on the wall at T&E that, we can do some testing, we can engage the clients when they come in and we can get even more aggressive with that, which I'm trying to do. We already talked about what the minimum standards for what we ought to test before we start treating people. As I mentioned, the clinical evaluation we're leaning on quite heavily, and I picked this up from studying what they're doing down in Central City Concern. They have a really nice questionnaire that they use that they validated for ruling out decompensated cirrhosis. But essentially, I'm looking at the person, talking to them, examining them, and feel that I can pretty comfortably rule out decompensated cirrhosis. The other thing that I mentioned is facilitated telemedicine. I mentioned the case that Mary and Maddie and I did to help with her care, but we're also using this in other areas in our drug user health, and also for HCV. Maria Velasquez, the great supervisor at TNE, who works closely with me with hepatitis C, she'll ring me up if I'm available. She'll have a client there, might have some questions. We can talk to them, lay out a plan, and kind of get them, do a little telemedicine on the spot and get them teed up to treatment. Maria we have developed some protocols for her to work just on her own to do some testing, but this can sometimes be helpful. So another thing about getting the medications. So we've used 2 specialty pharmacies. They've been very helpful. That's worked out great. We can pretty much get medicines delivered anywhere. I found it quite useful to just have them delivered to TNE because I can control the medications and know the patient's got them, etc. I was really pretty disappointed to not be able to work with a local pharmacist. I studied the great work that Dr. Judith Suey at the UW, working with HEP and working with Kelly Ross Pharmacy, and also what Chaz is doing, the CDTA pharmacy prescribing. I really liked those. I thought those were great. I tried to implement them locally. I found a local pharmacist who was really delighted to try to work with us. She looked at actually dispensing the medicines, and she would lose money to do so. So I thought that was a real shame that she couldn't do it. That said, the specialty pharmacies have been great to work with. The large majority of our clients either qualify or have Medicaid. So of course, the great program that we have at the state to be able to get the medications without any pre-authorization, that's been really well. We mentioned the case management, some of the case management aspects. We really are trying to focus on where patients go or where they are. In my example patient, Bill, he goes to the needle exchange. So that's where we contacted him, and we know how to find him there. Maddie helps me. She helped me with Mary, and we know she's at the homeless shelter, and so that information is helpful for us. Another thing that I found quite interesting, the state has had TNE doing all their reporting in REDCap. I think it's been since last September. And REDCap is a IT platform built primarily for research at Vanderbilt, but it's been widely deployed at universities and nonprofits. And it's really interesting because I've seen the staff transition at TNE from writing on paper and later on doing the reports to really having real-time use of REDCap right when they're seeing the client. And that's helpful for us to drop some messages in there. We try to keep PHI out of there, but we can message somebody if we know somebody that's been coming in for services and, that we need to kind of get a hold of them to deal with their hepatitis C. Another kind of interesting aspect I might add is that T&E uses a 6-character identifier, and I'm of course using first name, last name, date of birth because I got to keep medical records. So we can triangulate between those things and kind of figure out who people are to be able to connect with them a little better. REDCap I think has a lot of potential, even more so than the settings I'm seeing it used. So a couple of my observations here. I think harm reduction in Pierce County looks very effective to me. I mentioned the AbbVie van that we had come by, and we screened that day, we screened 158 people at 3 sites, mainly homeless people. I was really surprised to see less than 5% of them test positive for hepatitis C, the RNA. I expected 10 to 20% or more based on the national numbers I looked at. So I think to me, that was really impressed to me that I think the harm reduction done by T&E over many years is doing good work. We really haven't tested a large enough number of people, and I haven't really collected up the numbers to really say too much, but I feel comfortable that we're way less than 20 to 40% that I expected when I started this. I'm looking at national and international numbers. Another observation is the trust developed with the T&E staff interaction with the clients is really critical for us to get the engagement necessary to do the testing and the subsequent treatment. We can talk to the clients, engage with them, educate them, and it's really all comes from this trust that they developed with this relationship that they have coming for their supplies at T&E. So I think there's a lot of good things going on in Pierce County, but I think we need to coordinate efforts better than are currently happening. I want to get back to the slide because I wanted to make sure I was hitting the points I wanted to talk about. Again, I looked at what they're doing at Central City Concern, and I've really tried to approximate what they're doing. They actually have a really nice questionnaire that they validated that they can pretty comfortably rule out decompensated cirrhosis just with their questionnaire. I look at a little more clinical things as well, but I think they're really just what they're doing is really very interesting to me. Future plans, goals, a couple of my other thoughts. Personally, I would like to see us develop systems that are reproducible anywhere in the lowest resource environments. That's what I'm really focusing on. Let's look for the toughest people to treat and get to, such as Mary and Bill. I'd like to see better expansion towards HCV microelimination in Pierce County, such as the homeless, the carceral, in the OTP environments. I love the term microelimination, which I just learned dealing in this space, being the idea of let's look for where the disease resides. And these are the populations at the needle exchanges, these other environments. Let's look for disease there. I think that's the best place to be prospecting. Another thing, I believe that there's a lot of promise out there in some of the self-testing models for HCV that I'm studying a little bit out there. Another thing, I think that a facilitated telemedicine program for Washington State on a broader level for rural and underserved populations, I think would be very achievable. In fact, one of the Skunk Works projects I have is trying to do that. So if any of you out there are interested in helping me kind of pioneer that in the state, get in contact with me. I'm trying to do a couple of things there. So I did put a few references in there. The opt-out testing, there's a great paper on their work down at the University of Miami and their SSPs down there. They've increased compliance with their recommendations for testing from about 20% to 80% by their opt-out program. Central City Concern, on their website, they've got some information about what they're doing. And then the expert guidelines, I really like this link here to this simplified one that I mentioned. So that's it. Happy to field any questions people might have.
Thank you, Dr. Lang. I answered one of the questions that was in the chat, which was about if dried blood spot for Hep C and Hep B were FDA approved. And they are not FDA approved. They're lab validated tests that can only be performed at molecular testing laboratory because they're the lab that validated those. I don't know if they'd be covered by insurance, but where we've deployed dried blood spot testing, agencies aren't billing insurance for testing, so we haven't had to come across that issue. And I don't know if maybe Healthcare Authority could speak to that. And then Dr. Barash, I have seen that questionnaire. I think it might be available, but Dr. Lang, do you have Central City Concerns questionnaire to evaluate for decompensated cirrhosis? Is that something
I
you
can
could share?
get it. I'll talk to Andy Seaman and Arsalan. They'll probably be happy to share it. They have not published it yet, but I'm pretty sure they'd be happy to share it. If so, I will give it to you, and maybe you can just post it out there. But yeah, it's
Sounds
really
good.
it's really kind of neat because they validated it themselves, and you know, I think this is a very simple thing that people in the field very quickly can just kind of go with this, and with their validation, I think they can feel pretty comfortable that, you know, they can rule out decompensated cirrhosis. So here's, I don't know if people can see me here, but I've got the card here that we're using. I'll put it up to the screen. It's
Hey,
basically got,
Dr. Lang, maybe if you stop sharing your screen, then we can see
I'm sorry.
you, the screen of you
There we go.
bigger, and that'll
There we
help
go.
us see the
I thought I was
card.
already stopped sharing. I thought I wasn't sharing it. So anyway, here's the card, and I don't know how you can see it, but there's 5 spots on here. So it's, you can see it's about the size of like a Guaya card or something like that. And there's 5 spots, and we just do a finger stick, and you can drip it in there.
And then there's a question if treatment or testing is incentivized. Are you all providing gift cards to folks or?
Oh, we are not at TNE. So we did provide gift cards when we did the AbbVie Elimination Tour. You know, we did $10 gift cards for people that initially screened. We did the OraQuick test initially. You know, the people did anyway. And then if they tested positive, we gave a second card. So we gave $10 cards. I thought we really needed to do that to get people in. But at the Needle Exchange, I'm not currently doing any incentives. We may do a little bit of that to try to reel people in to get SVRs done, but right now, you know, I'm really leaning on the opt-out testing thing. You know, we're trying to engage people when they come in, talk to them when they come in, educate them. People have asked me about incentives, and I said, well, the incentive is your health. So that's what I'm working with now.
Emily, can I make a comment?
Yeah, of course.
So, sorry, let me get my. So I just want to say that really the success of this really is because Dr. Lang has really just kind of grabbed it and run with the ball. We're extremely fortunate to be able to work with him. He's really organized much of it. When he first came to me, he was like, I want to do Hep C testing. What can we do? At first it was, well, we need to do street medicine. And then it was, we need to have a regular weekly clinic. And then we need to get more people integrated. We've really provided him with space and asked him what he needs. He's asked for very little. And he's just really taken this on. And I think it's a great example of how we can leverage resources in the community at no cost to anyone, because none of this has been supported through other costs except for testing supplies from the state. And it's a great partnership to get people services when we're in kind of constrained resource environments like we are now. And like I said, it's really, Dr. Lang has really taken this on. He's organized the nurses, organized the volunteers and the trainings, and we're really fortunate that's happened, along with the retired providers and getting the clinic set up. So there are some resources available to do things like that. You just have to know where to look. It's taken us a while, but we're really ramping up testing, which is something I've always wanted to do. We now have testing available on a drop-in basis. Dr. Lang needs to get the credit that he deserves for really just grabbing onto this and like taking off with it. So I wanted to thank him for that.
Yeah, and I think it's just to piggyback on that, a testament to the importance of you have a champion who will not take no for an answer and just makes it happen come hell or high water. So Dr. Lang has definitely been that person and willing to do creative things to make this work in a setting that otherwise wouldn't necessarily have access to this. So yes, just sharing that gratitude, and we need to to replicate you, Dr. Lang.
I'm just saying, it's great to work with Paul and Stephanie at the Needle Exchange. Paul is very dedicated to serving not only his clients, but the underserved. He works very closely with the homeless advocates. And so it's just fun to work with them. And also Jan Runbeck over at MRC with the homeless support there. Paul and Jan and I just basically sat down and we're drawing plays in the dirt on how to do things. And, so it's fun to work with them.
Great. I see two hands. Judith, did you want to ask a question or comment?
Yeah, thanks so much for this presentation. It's really great. I really, and the work you're doing is terrific. I really like the use of the cases too, because it does sort of bring up these clinical conundrums. And so one thing, I mean, and just thinking about the first patient, the DBS, it's such a great use of DBS, right? Somebody, you can't have easy intravenous blood draws, and but there you don't have the platelets, as you were pointing out, like the DBS doesn't include the platelets. So, but obviously, like doing the physical exam, you can feel more reassured they don't have decompensated cirrhosis, which I think is reasonable, although there are some clinicians who might still be sort of uncomfortable with that, like not having an APRE or FIB4, which you need the platelets for. And then the second case I thought was interesting. As you pointed out, that person had been hospitalized, and so there were a lot of labs, and was wondering, like, had the hepatitis C viral load ever been drawn during the hospitalization? Because there you might think, like, maybe actually the cepheid wasn't really needed, and it might be that that person had all those labs when they were hospitalized, or should have gotten, or there's just sort of like thinking through how we can be efficient, and I think often when we see patients, they do have a lot of labs that are drawn, and as clinicians, we're sometimes lazy about like trying to get the old medical records to see. So it's just something else to sort of point out. But I'm envious of the access to the DBS, and just sort of thinking about how that can be made more accessible, and sort of the reimbursement issues for that, because I think that really could be very helpful for a lot of patients.
Thanks, Judith. Amber, I see your hand.
Hi, good morning. Yeah, the more about the dried blood spot testing, it does look like there's a lot of talk in it, and just sort of who you guys are covering that for the Tacoma Needle Exchange. Like, are there opportunities for other organizations to also utilize the state's resource around dried blood spot testing?
We can certainly talk about it. I will be honest that it's much more expensive than the other types of testing. So,
Okay.
It is not without its challenges.
Right.
And where there's access to other, rapid antibody followed by a RNA.
Right. I was thinking of it more for the Hep B, right? Like, I think that's the one thing where, like,
Yes. Yeah. I think we could certainly talk about it. Given current budget issues, I don't know if we have capacity to expand it, but we could definitely talk about it. And I'm going to put Patrick Dinwiddie's email in the chat. He's our testing coordinator. So we could certainly have a conversation.
One of the things I might mention is one of the things I might mention is hepatitis B. I kind of looked into that, and it's really a shame that we do not have hepatitis B point of care testing in the United States. There's at least 3 companies, 2 of them in Canada and 1 in Europe, that are very successfully making tons of money having a triple a triple test of hepatitis C, antibody, hepatitis B surface antigen, and HIV. And that would be great in the field, the settings that I'm working in. Man, if we could go in and just do a point of care test out in the field to check those three things out, it would be perfect. Because our typical patient is positive for hepatitis C. We have a very low incidence of Hep B and HIV. But once we got those three tests, that would greatly simplify, wouldn't be the cost for the hepatitis B surface antigen. So unfortunately, we don't have that available. There's some efforts nationally to get that available, but that would be really great if we had that triple test to use in the field.
Yeah, and there's some efforts. The Hep C diagnostics were given sort of a different classification by FDA to help expedite. That's why the Cepheid machine was able to be approved relatively quickly. And there's some efforts to reclassify Hep B diagnostics in a similar way. So hopefully that would open the door to point of care rapid Hep B test. But Hep B diagnosis is also more complicated than Hep C. So I'm just looking in the chat here. There's a question if you can run platelets on a Tasso draw.
One of the there's a mention. There's a kind of a blood collection device that you can kind of just stick on the arm to get blood out. And I think that has quite a bit of promise. We've been experimenting with that a little bit. Currently with that device, the Tasso device, platelet count is not available, although there is some effort to validate that testing by use of that device. If that was the case, which may happen sometime relatively soon, then a platelet count would be available without venipuncture.
There's a question. Is it a challenge following up with people when the dried blood spot results take 7 to 10 days?
Yeah, it has been. I mean, so far we've been able to contact people, and Bill, for instance, the guy that I mentioned, I knew I could communicate with him by text. His phone isn't always on, but he did. He was very interested in following up with his test, and he did eventually answer me. We did get him to pick up the meds, so it's kind of a case by case. It's been pretty helpful to use REDCap. We've had people that we got a test on them and they haven't showed up yet. Oh yeah, we look in REDCap and they've been coming like every other week, and then we can figure out, hey, message the when this client shows up, hey, bring it to somebody's attention here. We haven't really done this yet, but in people that we have a need, we're going to kind of have a letter that's going to be at the needle exchange for them to pick up. So we've been able to communicate with them, here's how you're going to get your results. But so far it's worked out pretty well by knowing which rocks to lift up to find the people.
Thank you. And then I feel like I missed another question. Did I miss a question? Oh, are you using dried blood spot to confirm cure after treatment for the SVR12?
We have not done it as yet. And I haven't really started to try to reel people in. I would try to, on some of our clients, like Bill, we wouldn't be able to do that. So, I haven't done it. I would probably discuss that with you guys before we did that. I think it would be a reasonable use of the test, although we haven't discussed that with you, Emily, about whether that would be a good use of the test.
I'm curious what Central City Concern does for confirming proof of cure.
The last time I talked to them, they don't bother too much with checking. I think they focus on getting people to take the meds, and they're just kind of good with that. So I think they don't spend their resources doing that, essentially feeling quite comfortable that they're just cured if they can get them to take their meds.
Yeah, and Judith, that was sort of my thought, is sort of maybe not using it for proof of cure because of the sensitivity issues. But yeah, I'd be curious. And I know, Australia is doing a lot of interesting things to do field-based Hep C treatment, and I'm curious what they do, if anything.
I will say the amount of testing, at least in King County, that we have going on, ultimately, we get that data eventually. And if testing levels stay high, I think a lot of people end up back in the system. And if they're still actively using, are going to get tested for Hep C again. So the RNA tends to come back is one thing we've noticed.
Yeah, eventually they get it somewhere.
Yeah. We'll lose a patient and then find them, we'll get a test result via surveillance, or we'll see it in a, EMR when we're doing a chart abstraction, because when we're looking for them. So our folks are getting tested a lot, which I think is good.
Yeah. A question, do you have medication storage for patients at T&E?
Yeah, what we're doing is kind of informally when we talk to the patient. We have a couple patients. We said, Bill, for instance, he lives in a tent, but he felt quite comfortable taking all of his medicines. He said, "Gee, I'm going to go to Las Vegas. Can I get all my meds?" I said, "Yeah." We had two other clients that I can think of offhand that, I don't know if I can take care of all these meds, so we're happy to kind of dole them out. However they want to take them. We have in our room in the back. We haven't. So I know I've heard of some people kind of having storage lockers if they have tons of people's meds, but we just sort of kind of have them in our back treatment room there that we can securely keep them and dole them out as the patients want them doled out.
Thank you. Any other questions for Dr. Lang or for T&E? All right. Well, thank you so much for presenting. I think what you all are doing is really creative and exciting, and it'd be great if we had more of this happening throughout the state. It's, a testament to what a little passion and a little bit of resource can do. So really appreciate you taking the time. And if folks have other questions for you, is it okay to share your email address, or would you like, I can always forward those to you as well.
Yeah, sure. I think I sent you my slide deck, didn't I, Emily?
You did, so I could share that out.
So it's on there. You can just put that. I'm happy to have people contact me. As I mentioned, we're happy to collaborate with some people, and I have a couple projects I'm working on that if people are interested in, I would be delighted to do so.
Great, thank you so much. Yeah, really appreciate your work on this, and really getting treatment to folks who, from the examples you provided, folks who've been walking around with Hep C probably for quite a while without access to treatment. And if it were not for you all doing this, maybe would be walking around much longer. So really awesome, exciting work, and I hope we can see more creative approaches like this. Yeah, and we can try to get that questionnaire from Central City Concern. I actually think they shared it at the INSU meeting in Portland, and I might actually have a hard copy of it. So if I find it, I will scan it and send it out as well. But Dr. Lang, if you are able to get it from them before
Sure.
I find it, let me know. All right, I am gonna stop recording if I can figure that out. Yes, I have stopped recording.